My name is Katie Menken.
And I'm Ashley Mutzel.
And I'm Jane Katz, and we're doing our capstone project on interventions and considerations for childhood apraxia of speech. What is CAS? Childhood apraxia of speech is described as a neurological childhood speech sound disorder in which the precision and consistency of movements underlying speech are impaired in the absence of neuromuscular deficits, such as abnormal reflexes and abnormal tone. Few evidence-based therapy treatment for childhood apraxia of speech are available. Lagasse from Colorado State University used MIT as a treatment approach for functional speech production in children with CAS. The two subjects were both diagnosed with CAS and were recruited from a speech-language pathology clinic nearby. Both of these subjects were male. English was their primary language. They were both able to produce 2 to 3 word utterances during the onset of the study. Patient 1 was 6 years old and patient 2 was 5 years old. They have both been in speech therapy prior to the study, and the study reported that they both had typical cognitive functions. The assessments that were given previous to when this study started were the Goldman-Fristow test of articulation and the Kahn-Lewis phonological analysis. The effects of MIT articulation were assessed immediately compared to a typical speech therapy session by a speech production test that was created by the authors. This study was conducted through alternating treatments such as an A-B design, where A represented a usual session with the SLP and B represented a 40-minute MIT session for 4 weeks. The results of this study showed that participant 1 had no progress over the course of therapy, although participant 1 did show more variability in scores after the sessions than participant 2. Participant 2 showed some variability and showed higher correct responses after SLP sessions and MIT sessions than participant 1. There were slight increases in scores of correct responses and STP scores after the SLP sessions. As a whole, participant 2 showed better performance after SLP sessions than MIT sessions. There were few strengths and many weaknesses in this study. The strengths of this study were that the parents of the participants gave their written and verbal consent that were approved by the Colorado State University Human Resource Committee. In addition, standardized assessments were administered at the onset of the study, such as the Goldman-Fristow and the Kahn-Lewis. On the other hand, the main weakness in this study was that the design of the study was a single-case experimental design. The interventions in this study were not isolated, so it was hard to tell if there were gains during intervention with the SLP without MIT being introduced. Also, there were no active measures taken during therapy, so the slight improvements that the children made during MIT and SLP sessions were not recorded. These slight increases of the test scores did not show to be significant changes when it comes to MIT being a treatment approach for CAS. Also, these results are not statistically significant. Children respond to intervention differently, and no two children with a disorder are the exact same. Therefore, these conclusions cannot be generalized because these 2 boys do not represent all children with childhood apraxia of speech. Another flaw would be that the children's focus and compliance during the MIT session was not very good. According to Lagasse, the clients were sensitive to touch, which caused distractions during the session, and the children had difficulty singing with the clinician in unison. This is probably due to the fact that the study found that MIT was not intrinsically motivating and it was monotonous, so the children had a hard time staying focused. Other weaknesses include the duration and frequency of the study and the preciseness of the SPT because it was not a standardized measure.
In my article, Murray, McCabe, and Ballard examined 2 different apraxia treatments on 26 children with childhood apraxia of speech between the ages of 4 and 12. They used a randomized control group study design examining experimental rapid syllable transition treatment, or REST, and the Nuffield Dyspraxia Program, or NDP3. REST is a program that uses polysyllabic nonsense words to mimic novel word learning and addresses segmental sound consistency, rapid and fluid transitions from one segment and syllable to the next, accurate production of stress, and demands that these three features occur simultaneously. NDP3 is a program widely used in the United Kingdom that addresses motor speech planning with a bottom-up approach, starting with isolated speech sounds and then moving up the speech hierarchy to more complex syllable shapes, then sentences, and finally connected speech. Dosage of each approach was controlled to 12 one-hour sessions, 3 days a week, across 4 weeks. The hypotheses of this study were as follows. Effects from pre-treatment to 1 week after treatment would be relatively the same due to high intensity in both approaches. REST would result in greater maintenance 1 month and 4 months post-treatment than NDP3, and REST treatment and NDP3 would result in greater generalization to untreated but related speech behaviors at 1 week, 1 month, and 4 months post-treatment than NDP3. The conclusion of this study was that experimental REST and NDP3 are both effective treatment approaches for children ages 4 through 12 with childhood apraxia of speech when conducted intensively. Some strengths of this study that were noted are the random allocation of participants, the use of blinded assessors. Because the assessors did not know the hypotheses of the study, they were not biased, high levels of treatment fidelity and reliability, as well as deliberately robust and specific criterion for an item to be judged as correct. While this article presented with strengths, it also had its weaknesses, which were that there was not a non-treatment controlled group used. Also, the authors did not discuss factors such as socioeconomic status of parents, as well as parents' level of education. Another factor that could have had an impact on this study was that regular SLP services were resumed after treatment and could have positively or negatively affected the 4-month post-treatment results.
The article I'm going to discuss is The Importance of Production Frequency in Therapy for Childhood Apraxia of Speech. This study was done in 2011 by Denise Michelle Edil and Christina Elk Gildersleeve Newman. The purpose of this study was to examine the importance of production frequency during speech therapy, whether more practice of speech targets lead to increased performance within a treatment session, as well as motor learning in the form of generalization to untrained words. This study included two children with childhood apraxia of speech that was diagnosed by a speech therapist that is certified as well as licensed, that has a lot of experience with childhood apraxia of speech. The design of the study was an alternating treatment A-B design. This study used 2 different treatments that included differing frequency productions. The first treatment was the higher production frequency. This treatment required 100 plus productions in the 15-minute time period. The second treatment consisted of moderate frequency treatment, requiring 30 to 40 productions in the same amount of time period, so a 15-minute time period. Child 1 was treated 3 times a week for 11 weeks, and child 2 was treated 2 times a week for 5 weeks. At the end of each session, probes were given to determine if generalization had occurred or not. Both child 1 and 2 showed improvement on all targets, but the targets with the higher production frequency treatment were acquired faster. This was shown by the child's better in-session performances and greater generalization to untrained probes. This study found both treatment designs to be effective, but more frequent and intense production practice of speech resulted in more rapid responses in treatment. This study had many strengths as well as many weaknesses. In this study, the researchers chose to target consonants that were different in place and manner to help avoid generalization of one target sound to another target sound across the two types of treatments. An additional strength to this study was that the researchers had a second observer that was blind to the conditions. This blind observer phonetically transcribed samples from the course of the study using broad IPA. This helps to ensure that interreliability was completed. Although this study had its strengths, it also had its weaknesses. The main weakness of this study is its population size. The population size was only made up of 2 children, and because of this, it makes it difficult to generalize the results of the study to a broader population. The variability of this treatment is also a weakness of the study. Child 1 attended the treatment session for 11 weeks, whereas Child 2 only attended treatment sessions for 5 weeks. The variability in the length of treatment could lead to some skewed outcomes. So for our capstone project, we are doing a case study on a 4-year-old boy who was diagnosed with childhood apraxia of speech. He was also diagnosed with childhood apraxia of speech by a licensed and certified speech-language pathologist whose main work is with children who have CAS. So this child is a typically developing 4-year-old boy who has childhood apraxia of speech. He attends pre-K and will be attending pre-K next year as well. He has been attending speech therapy since he was 18 months old. He started to attend speech therapy because his mother realized he was not meeting his milestones like his older brother was. He currently attends speech therapy 2 times a week for 30 minutes. He will continue to attend his therapy sessions while we are working with him.
The purpose of our study is to utilize aspects of multiple treatment approaches for childhood apraxia of speech. First, three clinicians will work with the child for 4-week time periods. One graduate clinician will implement melodic intonation. One will use the Nuffield Dyspraxia program, while another will use the Kaufman speech-to-language program. We will analyze the results of the tests to determine the effectiveness of each approach. Finally, we will combine the results to create one successful approach that implements ideas from each. We hypothesize that by combining these 3 treatment approaches, the Nuffield, MIT, and Kaufman, the child in our case study will receive maximum benefit in the areas of prosody and articulation.
We will work over the summer in 4-week time periods to work with our child in our case study. And then after all our 4-week time periods are up, we will come together and we will develop our own treatment plan using what we liked from each treatment therapy to ensure that the effectiveness will work with our child in our case study.
And in addition to this child's regular speech therapy every single week, we will be meeting with him 2 times a week for 30 minutes so that we can get the most out of the time that we're with him and see him multiple times a week. We will be in contact with his current speech-language pathologist and be able to know his progress and what they're working on in therapy so that we can see how that will affect our study and how effective our research and our therapy is with him.
So childhood apraxia of speech is a pretty severe disorder, in his case quite severe, but we are hopeful that with our hypothesis and with his other therapy outside of our capstone project, we will be able to help the child as best as we can. And here are our reference pages, and we thank everyone for listening to our presentation. Thank you.
Thank you.